It was mentioned that I'm from the New South Wales Sydney Region Engagement Team. Won't go into too much information, but I think it's worth remembering that our team covers what we call the New South Wales Sydney Region, and that includes northern part of Sydney, western part of Sydney, southeast Sydney and Sydney. So it's quite a large area, and although we might not be the biggest across the nation, we do have the most providers and the most participants that are transitioning into the scheme. Today, we will be striving for 4 main objectives as part of our presentation, and the first learning objective will be to help you understand what the National Disability Insurance Scheme is all about and how it is funded. The second objective is to help you identify the eligibility criteria to access the National Disability Insurance Scheme. The third is to differentiate the role between the NDIS and the health service system. And finally, we'll finish off on explaining what is reasonable and necessary decision making and how funding decisions are made based on this criteria. Throughout the session, we welcome questions, probably at the end of each presentation. So there'll be 4 presentations, and we want to make them as interactive and as useful for you as possible. So let's start off with what the NDIS, the National Disability Insurance Scheme, is all about. Remembering that all of us here in the room may be at different stages in understanding of the scheme. So bear with me if you cross this info, but I think it's worth going through it anyhow and remembering in this first slide just how significant the NDIS is in the terms of our society, Australian society, and remembering that it is indeed the most significant social reform since the Medicare rollout in the 1970s. And as you can see on the graph there, second largest, followed closely by the disability support pension and of course the aged care sector. So the difference between NDIS and the NDIA. You'll hear these terms both used interchangeably in our discussions, and really the main difference is the NDIA stands for the National Disability Insurance Agency, and the agency and its staff across the country are responsible to roll out the scheme, and that is the National Disability Insurance Scheme. So one NDIA to deliver the NDIS. And really the agency's job is focused on not just delivering the NDIS, but to building community awareness of disability. And that includes building awareness amongst your networks, but also amongst other networks such as networks for participants, other providers, and our general community. We also are here to ensure that there is a financial sustainability of the scheme. So we talk a lot about the reasonable and necessary criteria, and we'll cover that in our later part of the evening. And we also want to work with the community to develop and enhance the disability sector as a whole. So an example of this is tonight, but also on a larger scale, there are things available that you can participate in, and also grant opportunities such as the information linkages and capacity grants, and all of the information is available on our website. And that is another example of how we want to build awareness of disability and also enhance the disability sector and our community in general. And just to finish off, just a note there that the NDIA board governs the NDIS. Although we have had exposure to the NDIS here in this area since July 1 last year, it's still a very new way of doing things, and I'm sure you would agree. It's new in a lot of respects, the main and the biggest being that participants, customers, consumers are now the drivers of their funding. So one of the biggest changes that we speak of is the fact that customers now, or participants we call them, have control of their funds. So no longer do providers receive funding in a block funding sense ahead of time, ahead of service delivery. Things have completely changed, and participants now pay for their services after they receive them. So providers really need to look at their business and the way they practice, the way they do their day-to-day business very differently now. And we'll talk a little bit about that perhaps when we have some of the fruitful discussion here tonight. It's a new way because supports, when we talk about plans and funded supports, are completely tailored to the individual's needs. So supports are absolutely tailored to every participant's needs. So once a person meets access, their plan is like their own fingerprint, and it won't be the same as anybody else's. It's a new way because we talk about the scheme based on an insurance approach, which means that all of us here, taxpayers, are contributing a levy into a pool of funding that is used to currently fund plans and will continue to be used into the future. And when we talk about sustainability, we must remember that in another way, this means that we need to use those funds responsibly. So hence, again, while we look at the reasonable and necessary criteria, choice and control is absolutely fundamental. And although participants had choice prior to the NDIS, or for those of you who have worked in the industry and are familiar with what that choice may have looked like, for me, I know that that was quite often limited for the participant, and really it was quite tokenistic. And in a lot of ways, when a participant was receiving one type of service under block funding, it was almost impossible for them to move to another provider or to change the way that they were receiving that service. But now, with the NDIS, those two things are possible. And we've already seen since July 1 last year in the New South Wales Sydney region that choice and control taking place, which is really exciting. It's a new way because it's needs driven, so it's based on the individual's needs and their goals. So every single plan, every single part of that plan that is funded is based on that participant's needs. And in turn, those needs are linked to their plan goals, so their plan outcomes. Every plan needs to be made up of that person's plan, and that's how the supports get funded. It's a new way because it's delivered in local communities in the sense that it's everybody's business. So it's not just NDIS and the rest of us, it's actually the NDIS working in collaboration with all the stakeholders that are involved. And we talk about providers, we talk about participants, but we also want to work with mainstream services. We want to work with the community in general, because the NDIS in some shape or form will affect all of our working or personal lives. And finally, it's a new way because it's national coverage. So back in the old days, about 12 months ago or thereabouts, if we had a funded package that we were receiving in South Australia, for example, as a participant, it would have been almost impossible for me to be able to move to New South Wales for whatever reason. Wanted to change my life, or my family had moved down there and I wanted to follow. That was really difficult because I wasn't able to move my funding around, whereas with the NDIS, it is a national approach. So we're striving to be as consistent across our nation as possible so that participants can move their funding, not just within their suburb, within their local area, but across states. Now, the NDIA principles, although they might seem pretty straightforward, I guess we like to talk about them because it's really important to remember them when we're learning about the scheme and the purpose of the scheme, but also when you're interacting with participants, your customers, or just the general community. We need to remember the purpose of the scheme, and it will help us to then stay on that path to the future together. So Fundamentally, people with a disability have the same right as other members of the community to realise their potential. People with disability, their families and carers should have certainty that they will receive the care and support they need. People with disability should be supported to exercise choice in the pursuit of their goals and the planning and delivering of their supports. The role of families and carers in the lives of people with disabilities to be acknowledged and respected. And the reason I read that out is because I don't want to, accidentally leave out the importance of those points that I just went through, because they do align with the United Nations Convention on the Rights of Persons with a Disability, as well as the National Disability Strategy here in Australia. So really fundamental to remember that the scheme is underpinned by really strong principles. Three of the main pillars that underpin it. So if we break down the principles even further, there are three main areas that I'd like you to think about and take away today, and really keep reminding yourself about these when you are working with participants in the community. We've mentioned the insurance approach, so I won't go into too much detail, but the other thing I wanted to mention is that we're all covered. So at any point in time, if we were to acquire an disability and we need access to the scheme, then we can rely on a scheme that will be able to assist us with our goals. And depending on where we're at in terms of our disability and in terms of our life, therefore our plan will be matched up to that point in our life. And of course, plans will change from year to year, as will the funding associated with those plans. So it's really important to remember that because it is an insurance approach, we do need to refocus on the reasonable and necessary criteria, and we'll talk about that a little while. Choice and control, second pillar, incredibly important, and one of the reasons why I'm really excited about the scheme. We're really seeing a lot of it already. Participants where they've been stuck, say in a program that didn't really fit their needs, so they were perhaps surrounded by people that weren't their own age, or their activities at that program weren't really what they were interested in. But remember, with the block funding arrangement, they didn't really have any opportunity to move. But now, with their support coordinator, perhaps, and the opportunity to write their own plan with their own goals, they've been able to look at what's out there and, with support, liaise with the new providers, talk about what their future with them in terms of their working relationship will look like, what kind of supports will I receive, how much is it going to cost me, etc., and ultimately change their providers. So it's a bit scary for providers because there's a real sense of, oh my goodness, maybe I'll lose my clientele, but I guess that's an exciting opportunity for providers to really have a look at their business and get to know their customers. And if things aren't working, this is a really good opportunity to look at doing things in a different way in your business, so that you can, one, retain customers, but also encourage and get new customers on board as well in the near future. And the third and final pillar of the scheme is all about community and mainstream. And really important to remember that when we are working with a participant to gather all the information about their life in terms of putting together their plan, we look at what kind of informal supports they are getting or would like to be getting in the first instance, and that may include involving family, friends, community groups, for example. The second thing we look at is our community involvement and participation, as well as mainstream support. So we look at, what kind of community organisation exists out there that this participant would like to join up with, to possibly make some social connections in their community, and they're not necessarily funded supports. So just because I have a disability and a plan doesn't mean that everything I do in my life from here on end is to be funded. I too want to participate in my golf club, for example, to be part of a group, and I may need some assistive tech to help me, do the golfing thing out there. I'm not a golf fan, let alone, not a fan, but I'm not very good at sport in general. But if I was interested and I had a physical disability, there are aids that I can get and that are funded by the NDIS to help me actually get out there on the field and do what I'm passionate about, and that is play golf. But that doesn't mean that I need somebody there with me to help me play the golf, because I'm quite, happy and I can actually use that equipment myself. Yes, when I go back home, I might get some support, some paid support to do my household activities to help me live an ordinary life. So here we're looking at community and mainstream. So the other part to that is receiving or continuing to receive supports from mainstream services, which in your case, we talk about health and mental health services. So New South Wales Health, New South Wales Mental Health. We also talk about mainstream services in terms of transport, education, and so forth. So once we have a chat to the participant about all that really important information, we then move to the funded supports. So we would then look at, well, what else are your goals, and what funded supports will you need to actually be able to achieve them? And in our example here that we use, the golfing example, there could be funding there for assistive technology to actually help me get out on the field and play golf. And we'll talk about the differences in a little while. Now, the transition in New South Wales is the quickest across the country. So not only are we the most busiest in terms of numbers, we've also got to transition all these fabulous people within the shortest period. Nonetheless, we are up for the challenge and we will support one another to get there. So in New South Wales, July last year, we started the transition. So participants literally transitioning from their state-funded funding package to an NDIS funded plan package. And the areas up there you can see, including Northern Sydney, where we're sitting in today. As of July 1 this year, Illawarra, Shoalhaven, Mid-North Coast, Murrumbidgee, Northern New South Wales, South Eastern Sydney, Sydney, Western New South Wales and Far West commenced transitioning in terms of participants transitioning from state-funded programs into NDIS. What does that mean? Basically, receiving an NDIS plan, their first plan, and their state funding ceased. So the reason the transition has been phased in these particular areas is because there's up to 460,000 people across the country that are transitioning by the end of 2019-20 will be a part of the scheme, and currently there has been an estimate made that it might even be just slightly over that. So as you can imagine, we needed to have a phased approach and groups of people transitioning so that everything was going to be done without compromising the quality of that process. And speaking of progress, this is a snapshot of a lot of data that you can find in a quarterly report that the NDIA puts together and is responsible to reporting to the Minister. This one is a snapshot of the data that ended on the 30th of September this year. And as you can see, over 112,000 participants, people, Australians with a disability across the country, received an approved plan. In terms of dollars, those people's plans have funding attached to them now that equate to $9.5 billion. And out of those people, 6,716 were children, so little ones from 0 to 6 years of age. And we might not go into too much detail today, but I will mention that there's a different pathway for these little ones to come into the NDIA. And that's what we call the Early Childhood Early Intervention pathway. As you can see on the left there, the figures are pretty clear that New South Wales to date has completed the most number of plans, so 58 odd thousand people and we will continue to do that. So at the end of 2019-20, there'll be about 150,000 people in New South Wales alone with NDIS plans, and 460,000 approximately across the country. Part of the enormity of the scheme and the huge transition of 460,000 people into the scheme over a very short period of time is the fact that the agency couldn't do this by themselves and are continuing to work alongside what we call our partners, and hence why Angela is here today. We work very closely together, the agency and our partners. Uniting is our local area coordinator partner here in this region. And if we talk about the South East Sydney and the Sydney region, that would be St Vincent de Paul Society. And in the far west, that would be Social Futures. And if you look into other regions, such as the New South Wales Central region, such as the New South Wales Northern region and Southern region, you'll learn that there are slight differences in our partners and the regions they cover. But for this area, it is indeed uniting. So why have we commenced workings with our partners? Well, basically because we've needed them and we continue to need them to collect the information when it comes to plans. So local area coordinators have done a great job and will continue to do a great job in actually going out there into the community and speaking with participants that are transitioning from state-funded programs, getting to know them, learning about what it is they want to do in terms of their goals, helping them build the bones of that plan, so to speak. Once that occurs, that goes to a planner at the agency who will then have the delegation to actually be able to approve that plan. And all of the time that we are building this plan, we're thinking about what is reasonable and necessary. And we're looking at, okay, we've got funded supports here, but what about mainstream supports? What about community supports and informal supports? Let's look at the whole picture in this person's very important next 12 months. And a lot of the participants that Angela and her team are working with now are actually up to their second plan. So they've either come or they're coming to their plan review. Whereas in the South East Sydney region, all those participants are currently building or have just built their very first plan. Hence that phasing schedule and not making everybody go through the same process at the very one time in the whole entire Sydney region. Another example of our partners are the early childhood, early intervention partners. And I mentioned that pathway a little bit earlier on. The partners that are working in collaboration with the NDIA here in terms of access for the little ones from 0 to 6 years of age into the scheme potentially are what we call transition providers. And if you'd like to learn more about who they are, we do have very comprehensive lists on our website according to local government area. And they're responsible to, when they first make contact with the family and their child, to assess the child in their natural settings and where necessary, link them up with their community, link them up with mainstream services, get the child, reaching their developmental stages as soon as possible in terms of those initial connections. But if the child's developmental delay is quite significant and they're not going to catch up unless they get more intense therapy, then perhaps that child needs to, and their family, get assistance to submit a access request form. Once access is met, the transition provider will then recommence their working with the family in terms of putting together the bones of that plan, and the planner at the agency will then approve it, and the child will get those interventions very quickly. However, if they didn't need them and in the initial stages were able to be connected with their groups or their specific supports in their mainstream services, then that would have been the case. So I won't go through too much of that. You'd like to add?
I think I was just going to say 2 minutes.
Okay, no worries. And this is just to reinforce our New South Wales partners in the community and what it is that we do. As you can see, the map of New South Wales, quite clear where Uniting sits, and Social Futures as well as St Vincent de Paul. So at this stage, these partners are contracted until the June 2018 period to help us transition participants from state-funded programs. We've mentioned the early childhood early intervention partner approach, and really you've got that in your slides. I'd like to just mention that their focus is really on family-centred practices, and these are delivered in the child's natural setting. And it really does focus on the family and building their capacity in terms of being able to link up with community services and mainstream services. So that's the first section. Are there any questions about what the NDIS is in general?
Yes, with the babies and the young children
Yes?
that are developmentally affected, how does that, the assessment and the process start from when we've got our health providers, you know, our health workers from birth, then to the early family childhood centre, and then to the GP? I mean, so early childhood health centre, they assess the children completely too, and that's a local government assistant agency. So, which one, like not hospital, community and then the GP, which health provider contacts the agency? Because there's a lot of there's quite a lot of doubling up of work with babies and paediatrics, babies and community. So which one? And a lot of us do the same
Transition
work.
providers.
So which health provider starts the initial assessment to receiving NDIS?
Do you want me to? You can answer that, yeah.
Okay, so good question, and the answer is that the transition providers are there to actually be the first point of contact when it comes to a family member.
Yes, but how does the health professional, who does the health professional contact?
Right. You can advise the family to contact a transition provider, and if they give you permission to do that on their behalf, if you look at our website, you'll see the transition providers by local government area, and of course you will be able to refer that family to that transition provider, and they will take it from there.
So we advertise it, we let them know that it's available service and they can go forward with that.
Yeah, so this is only if the child is eligible for the scheme. So historically, community health services has been providing supports for individuals, and that will still remain unchanged. And that once the child is identified that they are needing early intervention supports, and then they would access the early intervention providers, and then it will be up to the family or the health professional to contact the ECEI providers.
I mean, there's obviously different ways that that could occur depending on what the family would like, and NDIS is an option, and by that I mean that the early childhood early intervention provider, the transition provider, could be that option. So if the family notices that their child has a developmental delay, then they contact their transition advisor and they will take it from there in terms of assisting them to actually link up with these services that Angela just mentioned early on. Or if the child really has significant needs and it's quite urgent that they get a lot more intense therapies, for example, then it might be that the transition advisor will assist that family with the access request process, and then if the child meets access, then they will assist that family to help build a plan for that child. But what we need to remember is that not every child that accesses a transition provider will actually end up getting into the scheme. The idea is for them to be able to link the child up early on to their mainstream and community services, and that's, I think, one of the examples that you used, Angela.
Yeah. Stay here, we'll answer questions together. Great. Does anyone want to mind?
Hi, I'm Linda. I'm very new to NDIS and DIA. I'm curious as to when a plan is being developed, people's needs change, and how long is a plan in place, and how does it get varied, and how do How's the key placed into what the person's needs are as they change?
So when the meeting is held with the family member and the person with the disability, the information is gathered, and generally the plan will be in place for 12 months. Understandably, that the circumstances for the individual could change at any point in time, and that's when we ask the family member or the person with the disability to contact the agency and go through a change of circumstances form to let the agency know that the current funding in the plan is actually not going to be able to meet this person's needs because there's been a significant change in need, and that they'll need a review of the plan. So that's the current process.
And I'd just like to add that the best way that I guess we and families, providers out there who are having those discussions with the participant who's actually going to go to their first plan or their second plan, and in the second case they could have a support coordinator. It's important that conversations are being had around how do we prepare for this meeting. So there's a lot of information available on pre-planning preparation and talking about goals that might not necessarily be the same in 5 years' time, but for the next year, what are my goals? Even though they might be very small goals, let's go into the meeting with that preparation, and also, if we would like, take along any sort of information such as any OT reports that I might have, any evidence or statements from a provider that I have been receiving services from for the last number of years, etc. So that when we get to the planning conversation, the local area coordinator or the planner has a real good starting point of where that conversation may end up in terms of funded supports.
I noted in the figures you provided that the NDIS was projected to consume $20 billion a year. And the other figures you provided, at the point in time when it had been collated, 9.1 of those billion had been spent on a quarter of the projected participants. 4 times 9 is 36. A bit more than 20 billion.
We'll take that as a comment.
Yes, thank you. Very good observation skills. Yep, we'll take that as a comment.
I got 2 questions.
Question 1.
Okay. Question 1 is that for the new applicants, so for the patient who go through my doors, and I found it quite profound disabled, so how can they apply to, or from your organization? What sort of services available for them? Number 1. Number 2 is that I do have a couple of patients who is in the scheme, and then they only come to my, because I'm running GP services, and also I've got some other health as well. They just come to see my dietitian, but they go elsewhere. So what sort of services, what sort of component, including in those schemes, who are going to review them, and how can they able to reply for them again in about 12 months' time? Thank you.
So your first question, which was about how to access the scheme, we will cover that in the second part of this presentation. So if you just hold that question, hopefully the presentation will cover that. The second question that you had about a participant or a person with a disability with a NDIS plan coming to your GP practice or your health service to see a dietitian, we want to ensure that it's clear that a person with a disability is still able to access your mainstream health services that are provided. So just because they have an NDIS plan which has funding in it, any health needs which that individual might have will be still met by the health service system. So I might actually have a situation where I have diabetes, I don't have a disability, but I still need to go see a doctor or a health professional for that. Same with a person with a disability who might have diabetes, their funding plan won't pay for them to see that. They will still be able to access the services through health.
And the third question is that we, as you say, that we do have allied health, so how can they, apply to become a provider for this sort of scheme? So.
I'd like to invite you to one of our provider information sessions, but just quickly what we cover in those is that process. So If you wanted to do a bit of homework ahead of that session, or you can catch me at the end, have a look at our website. There's a provider toolkit, and it outlines from A to Z how you can register. A lot of opportunities.
So, just out of curiosity, how many working parents do we have here tonight? Just a show of hands. All right, a good number of people. Great. So what I'm about to talk to next, hopefully will be able might resonate with you. So for myself, I too am a working parent. I have two beautiful children, 4 and 6, who are at home with their dad tonight. And part of my goal for myself as an individual is actually to be a good working family mum. And part of that would actually be for me to be able to be a good family mum, to be present for my children when they need me, to be available at their school activities and their events, to be able to get down on the ground and be able to play with them when they want me there. But also part of being a good family mum is to obviously take care of those household chores which enable our family to be ongoing and happy. But the other part of being a working mum is that I actually get a lot of fulfilment in doing my role. I get a lot of fulfilment and satisfaction in being able to contribute to society and being able to add value and being able to earn an income to then be able to contribute to my family. So I hope that story resonates with a lot of you here, because I now want to share the next story, which is about my friend David. So David, same age as me, has also 2 children, same age as my 2 kids, and his goals are exactly the same as mine. He wants to be a good family dad. David has mild cerebral palsy, and so his ability to do the things that I want to do as being a good family mum, he wants to be a good family dad, to be able to get down on the floor and play with his kids, to be able to attend the school events and be able to be present there, are a little bit challenged because of his diagnosis of a mild cerebral palsy. So both of us, we have family and friends that are available to support us, and they are what we call in the agency landscape informal supports. So he has a loving family in Canberra who is able to support him when they come up to Sydney, but that distance is a little bit hard, and I'm very fortunate that I've got my parents-in-law who live very close, where I can just drop off the kids if I need to, if I ever need that immediate support from them. But also for him and I, we have what we also, our community, people around us that are able to support us. So for myself, I was connected to the local library where I was able to go to a reading group after school with the kids. So that's been really great, and from there I've been able to meet some parents in that environment, which has been fantastic. For him, he's part of a local church community, so he's connected to people in his community through his church, and they've been able to come over and help him out around the house, and he's been able to form some really great networks there in community. For me, government services and what the agency refers to as mainstream supports, I've been very fortunate to be able to access that without too much difficulty, to be able to continue to fulfil my role as being a good family woman and being able to be a working mum. So I've been able to access the Sydney public transport system without any problems to be able to get to my workplace, and I've been able to access the health service system without any difficulties when I've had issues with my health. For my friend on the other hand, he, because of his mild cerebral palsy, isn't able to access his local train station. There is no disability parking that's available for him, where he can easily access the station. He has a lot of pain walking upstairs to be able to get to his station, and so he has identified that he will ride to work on a motorised electric bike, which is great for him because he really enjoys that. But the problem arises when it rains, and he then finds it really difficult to fulfil his role as being a good family man or a working dad. He's also able to access the health service system without any difficulties. For any of his health needs, he's been able to go there and see the hospital system and whatnot. But because of his mild cerebral palsy, he needs a lot of modified equipment and orthotics to be able to move around comfortably. And that specialised equipment isn't funded by the mainstream services. However, for him, the National Disability Insurance Scheme is where it meets that particular gap. So why do I tell you this story? It goes back to this slide that the NDIS is a scheme for all Australians. And resonating back to what Monika spoke about in her presentation earlier, is that the National Disability Insurance Scheme is exactly that. It's an insurance scheme. We are all paying for this scheme. Now, does anyone remember from Monika's earlier slide how we are paying for this? Tax. Levy? Okay, exactly, Medicare levy. And we've got a special prize. If anyone knows how much, what's the percentage of our Medicare levy that's going towards this? So it was 1.5%, which has just recently increased to 2%. So it's a $22 billion scheme. $22 billion scheme by the time it reaches maturity in 2020, hoping to support 495,000 people with disabilities, which is massive. And this money that we're putting in from our taxes towards this scheme means that the child tomorrow that's born with a disability will be able to access the supports that my friend David never even had a chance to think about previously. And you know what, as an Australian, I'm actually quite proud of that. And I think each of us are as well. But it's also to remember that the National Disability Insurance Scheme, as well as being a scheme for all Australians, is understanding how does this actually resonate with each of us individually who are sitting here today. So if you think about the supports around government that are currently provided to all of us, and I talked today about transport, and I talked today about health. Does anyone know the quickest way for government to make changes in society? What do they do? Just a hand or a call out? The lady, sorry? Education is one thing, but the other piece, think about seatbelt. The gentleman over there, can we give him an umbrella, please? Thank you. So this is our lucky door prize. Absolutely. Over here, it's a golf umbrella. Thank you. It is pink, uniting colours, but it's very good. So legislation, absolutely. Through legislation is how you quickly get changes in government services. So the piece of legislation which Monika referred to earlier in her slide, to make these changes around inclusion for people with disabilities and changing the way that government services are currently looking at how to include people with disability, is through the National Disability Strategy, which is a federal strategy. But locally in New South Wales, who has heard of the Disability Inclusion Act? Yeah. So if you're working in any government service, at state level or at local council level, you would probably be involved in disability action planning. So locally, and this is mandated, it's legislated for all government services to have some sort of disability action plan to ensure that their services are inclusive of people with disability. And we're talking not just about a ramp or a rail, we're talking about how we can make communities more inclusive. Okay? So the next part of change in this disability insurance scheme is changing community, changing the way that we see people with disabilities in our community. And this is probably one of the hardest bits, because it's about changing the hearts and minds of individuals. So again, Monika referred to this in her earlier slide. Does anyone know what that framework is called that they're hoping to achieve this through? It stands this ILC. information linkages and capacity building. So through ILC, information linkages and capacity building, this is where we're hoping to change the hearts and minds of people in community. So if you go back to me as an individual, I talked about my informal supports, I talked about the community that I am in, and part of the community that I am in is where I work. And I'm trying to change the way that where I work becomes inclusive of people with disabilities. And this is how it's happening. So as a leadership team, where I work at Uniting, very early on in the year, we identified a disability employment target that we as an organisation wanted to reach. We were very deliberate about it, and we identified a 15% target for people with disabilities to be employed in our organisation. Very deliberate. And for that reason, we have actually been able to achieve that target, where we have actually employed now 16.2% of our staff and our workforce being a person who has identified as as having a disability. We're very proud to do that because we in community, as part of my community, made a choice. We made a deliberate choice to want to allow and target people with disabilities to be employed in our program and actually gain meaningful employment, not just voluntary work or it's paid employment. We have had the support of disability providers to be able to make the appropriate recommendations and adjustments plans so that we can actually do that. And whilst the target may not benefit my friend David, but it's going to benefit someone else. So I just wanted to talk to that because it is absolutely a scheme for all Australians. And each of us here at this point in time, if we take off our service provider hat and think of ourselves as citizens, as an individual in community, we can actually contribute to how this scheme is going to look and roll out for someone with a disability. So the question that we get asked the most is then, okay, that's great. This is my role as individuals. What about for someone who needs funding? So absolutely, there will be then those people who will need to meet the NDIS criteria and the eligibility guidelines to be able to access those funded supports. So we wanted to talk to that very quickly. First of all, you need a permanent disability, permanent disability with a severe functional impact on the person. So I've had questions around, well, what if I don't have a formal diagnosis? That's not a problem as long as we have documentation to identify that the individual has a severe functional impact on their ability to carry out day-to-day activities and ability for them to achieve their roles. Age, under the age of 65 to be able to access the scheme. Residency, you need to be an Australian resident or hold the relevant visa requirements. And you need to be in an area where the NDIS is currently rolling out. And so for people over the age of 65, we'll be able to access services through the My Aged Care system. So in terms of determining access and how to access the scheme, which the gentleman over here was asking about earlier, there is a role for health professionals to be able to do that. And part of that is actually understanding the types of supporting documentation that is required to support someone to fill out an access request form. So there is a process of a form which is available via the agency to complete, which goes to the agency to determine whether or not someone will be made eligible for the scheme. And it's really important to recognise that the types of supporting documentation that is there to needs to be able to support that person's and identify that person's functional impact of their disability in various areas. So this is an example of the areas of the access request form. So it'll ask for the individual's details. It'll ask for privacy consent. So that is actually consent for the agency to access the person's DHS customer reference number, or their CRN. It'll ask for the parent or legal guardian if someone is under the age of 18, and also the carer's details. The most important part is actually Part F, which is the disability support. So this is where we talk about the functional impact of the person's disability. And finally, it'll also ask for a change of circumstances, that the individual will be obliged to notify the agency if there is any change in the individual circumstance, and also a signature, just to confirm all that. So when we talk about, if we go back to Part F, which is the disability support, and what we talked about functional impact, what does that look like and what does that mean? So in writing the supporting documentation, what the agency really wants to identify is how is that disability or the individual's diagnosis impacted? How does it impact on their day-to-day life? How does it impact on their mobility? So for example, you would have heard that story about David. He, because of his mild cerebral palsy, has a lot of pain. He has a lot of pain, and which impacts on his ability to walk long distances. As a result, he actually requires modified orthotics and footwear to ensure that he's able to mobilise around the house. So it's talking about how the disability is impacting on various parts of his life, and in this situation, his mobility. Communication. What is the functional impact of the person's disability, and how does it impact their communication? So for David, no problem. But for a child with autism who has no language skills, their communication, because of the diagnosis, will severely impact on their ability to exchange and be understood, and also be able to communicate their individual needs. And their inability to be able to do that results in behaviour which impacts on their day-to-day life. So it talks about, again, the disability, how does it impact on their ability to communicate, and then so forth with social interaction, learning, self-care and self-management. And self-management is about the ability for the person to make decisions in their life and whether they can manage their own finances. So not so much relevant for a child, but perhaps for someone diagnosed with a psychosocial disability who have bouts of ability when they are able to do that, but then when they're not as well. So again, giving some really good descriptors and definition in identifying how their diagnosis impacts on their ability to make decisions, and when that happens and how does that look. Any questions so far? Okay.
Excuse me?
Yep.
Where is it written that which is the permanent disability that is the one that deems the person able to take up, to be a participant under the... Because I've got clients who've got multiple disabilities,
yep,
but I haven't seen it written which one, or is it all of them, or...
So what we do want to find out is the primary disability that has the most functional impact on the person's life, but also we want to have it written down when we receive the documentation what the other diagnoses are that actually also impacts on the individual's life. But it is actually written in the NDIS, I think it's the guidelines, in the NDIS guidelines of what those disability types are. Yeah, yeah.
Yeah, it's just that if you're wanting to provide something for that client,
Yeah.
and then you say, oh, hang on, no, that should be under mainstream health, providing a walking frame or something,
Yeah.
whereas, they've got rheumatoid arthritis and they're schizophrenic and they're, and 3 or 4 other things as well. So
Yep.
just to be sure that, you're providing something which relates to the disability, that's acceptable.
Yeah, and relate to the functional impact of the person's disability. Yeah, absolutely. Yeah, there's a question over there.
Just ask, what form of documentation is required to prove whatever disability, and what's stopping people do fraudulent behaviour here to access the funds?
So first question, which is what's the supporting documentation that's required? We would require a formal diagnostic report from an individual, from a professional, trained professional who's able to carry out those assessments. So for someone, say for example, a child who with autism, it would not be suffice for a speech therapist who's treating the individual for communication disorder to then in her report say, or his report say, I believe this child has autism. That won't be accepted by the agency. We would need a diagnostic report from the paediatrician. It actually talks about what specific assessments are actually required for those diagnoses as well. And your second question, which was?
Yeah, so I guess that helps explain why how people would not do this fraudulently.
Yeah.
So
Yeah.
To get funds.
That's right. Yeah. I wouldn't be able to ask my neighbour to write, in good faith.
Because you gave an example before of someone who didn't have a diagnosis specifically but could potentially still access the fund. How would that work?
So that came from a question from, so there are some rare genetic disorders or some rare disability or diagnosis, which doesn't actually have a name. There's no label.
Okay.
There's no
So
name.
That's very much an exception.
Yeah, exactly. As long as the reports from the health professionals actually identify that this child's unknown diagnosis is severely impacting on XYZ. Yep.
Thank you. Just to add to that, part of the access request form and filling that in is if one doesn't have reports or letters or assessments that they hold from either a health professional or an educational professional, etc., outlining impact of the impairment on functionality, then part of the form is to be taken to their GP, for example, or a psychiatrist, and they actually can fill that form on their behalf, and they will draw on other specialists that they may have had contact with through the years in relation to that person to gather those reports and those assessments so they can then fill in the access request form and those required functional domains and sign off on that with their qualification, and that will go in as the person's access request form. Hence why it's so important that all of us here are in the room tonight.
Is that a Medicare rebatable service?
No, not that I'm aware of at this
So they
point.
have to privately pay us for that consultation?
Well, like if a person comes to see a GP, they can, I understand, bulk bill that as a normal appointment.
Yeah, I don't know if you understand what I mean. Some services
Mhm.
are not able to be claimed through Medicare, where the doctor privately bills
Right,
it.
okay.
That's what I'm asking, whether
Okay.
this is a Medicare.
Is that
service.
something that
Yes.
you wanted to add to, Anne? I'm not familiar with the billing or non-billing.
So like,
Okay.
let's say someone came to see me and said, I don't know.
I understand what you're saying. So they would come and see you to help, you
Is the
to...
consultation applicable for me to charge a Medicare item number to the patient?
As long as documented.
It used to be, for example, workers' assessments for work.
Right,
you
okay.
have to pay privately for that service. That's what I'm asking.
I think it's probably worth finding that out, but in terms of answering that now for you, I
Okay, that's fine. If you
I don't have the answer, no. But the importance of a GP assisting a participant or a potential participant to fill in this part of the form is absolutely fundamental in a lot of people's cases in order to be able to access the scheme. Thanks. Okay, so it is covered.
Okay. So Anne from New South Wales Health has just advised there is a GP fact sheet that will be released from the New South Wales Ministry of Health. Yep. And there's one in the pack as well. Look, that takes me to the end of my presentation.
Okay, so the next part of our presentation is exactly to talk about the interface between NDIS, the health system, and the mental health system. So we're not going to be able to go into absolutely every example, but in this case, perhaps we can explore that a little bit further because, for example, substance abuse that will remain with the health system. So the NDIS will potentially assist that person with their functioning, which clearly, in this case, would be affected by their alcohol and drug abuse. So how about we go through the next session, and hopefully it will provide you with more clarity, and what we can do at the end is use that as a bit of a case study, if you like, just to explore it. So is that okay? All right, well, let's just go to the next session then. Where's the little flicky thing there? So a bit of an introduction first in relation to NDIA and mainstream services or systems that we've already mentioned. And one of these systems are the New South Wales health system, which is quite applicable to those of you in the room here tonight, as well as the mental health system. So it's really important to remember that the NDIS is not here to replace any of these systems. If it did, it would be completely unsustainable. However, what we will continue to do is work alongside our mainstream services on a local level in terms of continuous conversation and engagement around actually applying what we call the Coalition of Australian Government Principles. And I'm not quite sure if this is in your pack, but if you Googled COAG principles, you will get a very reader-friendly document, and it does go through the details. It's legislation of what NDIS will fund compared to what New South Wales Health will fund and mental health will fund, etc. On a local level, we're working to provide greater clarity around the differences, so that if there is a situation where a participant is accessing a lot of mainstream services as well as the NDIS, how do we work together to ensure that they receive the adequate supports from all of those services? And on a local level, we work with Anne, who's here tonight, and we have a direct contact line with her, and we engage on a regular basis around these particular cases where participants are incredibly vulnerable to fall into the gaps. So we need to work together to understand and continue to explore what health covers versus what NDIS covers. So today we will introduce you to some of these differences. Wherever possible, the NDIA wants to strive to assist participants to access mainstream systems. And the key principles we've already discussed are around determining whether the NDIS or in fact another system is more appropriate to fund a particular support. And remembering that a participant's plan, although everybody's plan will look different, it's really made up of the core of what their informal supports will look like, mainstream and community networks, and of course some of the funded supports that will go with that as part of the NDIS pool of funds we spoke of. I think this slide really defines what health and mental health systems will continue to work with participants on. So whether they are an NDIS participant or whether they're a typical Australian that just happens to access the health and mental health systems, as part of the Inclusiveness and the Inclusiveness Act and the legislation that is in place for all the different funded mainstream services. In this case, they will need to provide clinical intervention or medical treatment. So in terms of mental health, for example, health and mental health systems will continue to manage psychiatric conditions and mental illness. But we can talk a little bit about how the NDIS will actually work in collaboration with those systems to make sure that that person meets their goals, their outcomes. And it's good that you brought that example up because it's very timely. So we will come back to that. Individuals and families will also sometimes have a role in funding medical and clinical services, such as any out-of-pocket expenses or gap payments, because the NDIS doesn't cover these. So remembering the document, the COAG principles, so the COAG principles, the Coalition of Australian Government Principles, and they're in place to determine the responsibilities of the NDIS and other service systems. The document is about 25 pages long, and it is really user-friendly, and And the part that you would probably be most interested in is the first part, which is the health part, which covers probably around 4 pages. So it's not a overwhelming read at all. But what it does is it defines further how NDIS needs to work in consultation with the health system and vice versa. And in order to do that, we need to really be clear about who funds what. And as you can see on there, NDIS will fund supports which help the participant manage their ongoing functional impairment that result from their disability. So functional, Angela mentioned the 8 domains. It includes how does my disability impact my communication, my day-to-day communication, my day-to-day general, ordinary type of life situation. So getting out of bed, how does my disability affect me getting out of bed? So the health system might be treating my condition on this side, but at the same time, my disability prevents me from being able to get out of bed by myself. So I may need funded supports by the NDIS, so support workers to come into my home every morning, for example, to help me get out of bed, perhaps assisting with the hoist, assisting me with my personal care, so helping me to have a shower, perhaps, assisting me to make my breakfast, get ready for the day, potentially provide me with travel training as I use or continue to use New South Wales transport. Obviously, the NDIS won't pay for my tickets, but they're there if need be, and it's part of my plan to actually help me to learn how to catch the train by myself so I can get to work. So supports that enable participants to undertake activities of daily life that I've just mentioned that all of us need to do in order to survive. So they're the core parts of our life. They're non-clinical supports. They include aids and equipment. And of course there are some exceptions, which includes nursing care. The health system is responsible for assisting participants with clinical and medical treatment. No doubt these terms are incredibly familiar to you all. And this includes diagnosis and clinical treatment of health conditions. These are ongoing or chronic conditions. They include supports directly related to maintaining or improving the health status. So Angela mentioned diabetes. The health system has an incredible responsibility to ensure that things are in place in our society to, one, prevent diabetes, but also assist people with diabetes to live a better life in terms of their health. And that may include education on how to actually do that. It may include supports directly related to maintaining or improving their health status. We mentioned that. Rehab and support after a medical or surgical event. And important to remember that if that was an acquired brain injury, for example, I've had an accident, and because the scheme is here now to provide an insurance approach for all of us, so we're all covered when we need, while I'm in the hospital, I will be provided with the adequate medical and surgical support. However, my life has dramatically changed now. So I may now actually meet the access criteria to the NDIS. If I do, that means that as a result of the brain injury, I now have impact on my functionality. So I no longer can communicate as effectively as prior to my accident. I no longer can actually do all the bits and pieces in the morning to actually get me out of bed and even think about now going back to work. So you can see the difference. Yes, the hospital will take care of my medical treatment, my health condition needs, but once I come out of the hospital, of course, I'll need different types of supports, and that may very well include funded supports from the NDIS. Although, moving forward, I will continue to use mainstream service such as health, but also be able to now improve the functionality of my life so that I can live an ordinary life by using my funded supports from my plan. And of course, medications and pharmaceuticals, NDIA won't fund those. There are still responsibilities of the health system. Well, what if the health and mental health systems don't actually fund the supports that I need? And I'm not eligible for the NDIS. The best example here we can use is that the local area coordinators, and in this region there's Uniting, are people that can actually provide some support to these participants to be able to link up with providers, their community, that may be able to help them, get back on track, or perhaps access those community services in order to live an ordinary life. There are also ability linkers in our community, and that may be a service that a local area coordinator could refer that participant to. So before we go to the next bit, can I just go through an example of what the lady at the front here referred to, Angela? It'll just take 5 minutes, but I think it's really important. So before I do that, I'll read out some examples of what the NDIS is responsible for in terms of mental health or psychosocial disability, and also what the health system or the mental health system needs to provide or continue to provide. These are just some examples, and I do urge you to read this document. So the NDIS will provide reasonable and necessary supports for eligible people, including support for community, reintegration and a day-to-day living, including developmental of skills, assistance with planning, decision-making, personal hygiene, household tasks, etc., and community connections provided other than where provided as an integral part of an established treatment program. On the other hand, the mental health system will need to continue to provide services and therapies in which the primary function is to provide treatment of mental illness targeted towards people affected by mental illness or psychiatric condition. So including acute and non-acute residential services, mental health crisis assessment services, hospital avoidance services, and post-acute care services. Just to pick one more, NDIS will provide reasonable and necessary supports for eligible people with capacity building support to help the person access and maintain participation in mainstream community, including recreation, education, training and employment, housing and primary health care. Whereas on the other hand, mental health services need to continue to provide early intervention designed to impact on the progression of a mental illness or a psychiatric condition, especially where delivered by health services. So these are just a few that I've taken out of this really important document, and if I can just finish off by describing just a number of these functional domains that Angela mentioned that are part of the access request form. For your example, who is somebody who may very well have a psychosocial disability, and it's important to remember that not everybody with a mental illness will actually have a psychosocial disability, which means that their mental illness has affected their functioning in their life and is likely to be quite significant and permanent. So for example, very quickly, those functional domains, if we pick the first one, which included mobility, motor skills, we need either the psychiatrist completing that form or perhaps the GP to talk about the symptoms. So it could be in a case of somebody with psychosocial disability that they have paranoia, anxiety, low confidence, side effects from their medication such as weight gain and lethargy. In the actual access request form, we ask for examples of the functional impact. So thinking about everything that Angela and I have said already in relation to that, in this case, for mobility and motor skills, this is how the person's functioning has been affected. So they've got difficulties using public transport, leaving the house, going to shopping centres, attending recreational vocational activities. They have mobility difficulties as a result of the weight gain, for example, a reluctance to travel alone to unfamiliar environments, refusing to travel alone. So what are some of the supports that are recommended or should be considered as part of that process of potentially meeting the access requirements of the NDIS, and what are some of these supports that can actually be funded by the NDIS as opposed to the mental health system? So this may include support workers to accompany this particular participant when they're using public transport, provision of transport, some low stimulus options, perhaps funded supports for personal support to build confidence and provide feedback to that participant. And finally, perhaps aids and equipment for that participant to overcome movement difficulties and to help them cope with the systems as they are accessing the community, which in turn you would be able to link to their goal and their plan, which would quite clearly be, to access the community more safely and confidently. So I don't know if you want me to go through another example, but that's what we're looking for when we talk about the functional impact.
So just very quickly, I wanted to talk, and we'll spend literally 10 minutes, maybe 15 on this, if you could bear with me, around reasonable and necessary decision making. And part of the reason for that is because it's legislated. Reasonable and necessary decision making is legislated under the NDIS Act, and it is actually the language which agency planners use to decide whether or not something will or won't get funded. So I think as a sector, we also need to be aware of what this language is, so that when we write our supporting documentations or when we are advising families certain things can and can't get funded, this lens is applied when we make those recommendations. So I'll just talk you through that very quickly. And I quickly mentioned the NDIS Act. It governs the entire scheme. There are several decision-making frameworks that underpin and underlie all of that. But ultimately, if there is any discrepancy between anything in the green versus anything in the purple will trump what's actually underneath. So it's just to be aware of that. But also there in your slide, it talks about some of the decision makings that underpins the decisions for the NDIS Act. What the NDIS will and won't fund, I won't go through that. You can read that in your own time. But I just really want to quickly spend some time talking to this. So the first thing is under reasonable and necessary, what does this actually mean? We use it a lot. The language is spoken about all the time. But essentially there are 6 criteria under this Act which guides the decision making. And the Act actually does state that if you're requesting for funding for anything, it actually needs to meet all 6 of those criteria. So let's go through that just quickly. The first one is the funding request or what you're requesting for will assist the person to pursue their goals and aspiration. And this is the goals and the aspirations that is in the person's NDIS plan. So whilst I might have goals to travel and to do all sorts of things, but if it's not in the NDIS plan, in my goals, it won't get funded. So it has to absolutely be captured in the person's plan. And when we talk about goals, we're not talking about the goal to get 20 hours of speech therapy services so that I can, a week, so that my child can have the supports. That's not a goal. The goal is about the functional. Think about the function. So the goal is about ensuring that my son who has autism can participate in a learning environment in their school and be able to contribute to develop meaningful relationships. And part of that's a goal. And part of a way to achieve that goal is to have an ASA agency for funding to have speech therapy support. So that's we need to make that very clear. The second part of the criteria is that it will facilitate social and economic participation. So it's self-explanatory in that it will help the person participate in the community or help the person assist meaningful employment. The other bit is it's value for money. So the agency would like to see that when you're asking for pieces of equipment to be funded or certain elements or funding, that it is actually value for money, that you've actually trialled it with the individual, that there's that, you know, if the agency, and I hear this all the time, the agency can fund, if a Holden and a Rolls Royce will do exactly the same thing, obviously they'll pay for the Holden. So that's what the agency is wanting to see, that you've trialled several pieces of equipment or made several trials, and that's actually worked, and the one that is able to meet the person's need, which is most value for money. It's effective and beneficial for the participant. So it needs to be evidence-based where we can, if we can find that, or it has to show that we've been able to help the person achieve outcomes in meeting their goals. So an example of that is that we see a lot of requests for apps for children with autism, say for example. So, you know, we'd like to see that those apps have actually been trialled and it actually has some really good outcomes there. Reasonable expectation of informal networks. So this is a little bit tricky, but essentially what it's actually asking is is it reasonable for what you're asking for the agency to fund to be paid for by the agency ordinarily? So I'm trying to think of an example. After school care. Gyms is an example, exactly. So, you know, you and I who would like to access the gym, we would normally pay for our own gym membership. We wouldn't necessarily ask for the agency to pay for the gym membership for that person, for the person with a disability. And then, is it most appropriately funded through the NDIS? And that's what we were talking about through mainstream supports and some of the conversations that we've had here today, is that there are various ways that an individual as a citizen has access to services and support for various parts of their lives. And health, mental health, transport, education are some of those avenues which I would be able to access as a citizen. And the same thing for a person with a disability. But for the disability funded supports that's being sought after, is it more appropriately to be funded by the NDIS versus some other system?
To what extent is someone who's got third party cover or a payout from workers' comp or some other
Good question.
incentive to insurance, to what extent is their access to the
Yeah, so
limited?
yeah, that's a very good question. Thank you.
I thought I got out easy. Well, the question first comes up in the access request form. So it does ask the applicant, even if they are, you know, just potentially going to enter the scheme, if they are receiving any compensation payments. And that is actually explored during the whole access process. If, for example, they are able to access the NDIS, during their planning conversation, there will be discussions around what is actually funded under the compensation versus what isn't, and what is reasonable and necessary to fund for that person in order for them to be able to function in an ordinary life. So we do have people that are in the scheme that are receiving a proportion of their funding for their life, you can say, from Compo, but on the other hand, they've also got a plan, although it might not be as big a plan as it would if I didn't have the compensation. So there are scenarios where the two can go hand in hand, but it does need to be explored at the point of access, yes. All right, just to finish off, thank you so much for having us here this evening, and some great questions, great conversation, and we've just really touched the iceberg, the tip of the iceberg, I should say. If you would like to find out more, both Uniting and NDIA hold joint and also independent information sessions. All of the details are available on our website, the ndis.gov.au website, and on the events page you will find upcoming sessions on a variety of different topics, including plan implementation, including support coordination, as well as provider portal workshops. So we're here to provide you with information and to build your capacity, so please don't miss out. Register for one of these sessions and we'll see you there.
Thank you.